So it's my pleasure to introduce our speakers. Kayla McDowell is an occupational therapist with over 8 years of experience supporting clients in various settings, including both inpatient and outpatient rehab and community care. She's also spent the last 4 years in a leadership role on HHS's Occupational Therapy Practice Council, advocating for the important role of OT on the interprofessional team. Brenda Dory is an occupational therapist with over 10 years of experience in stroke care across the continuum. She's worked in acute care, inpatient, and outpatient rehab, as well as covering the stroke navigator role. She is motivated to always provide quality stroke care and work collaboratively as a team to enhance patient outcomes. And Michelle Bonafiglia is an occupational therapist currently on the outpatient neuro rehab team, working with stroke and ABI populations. Michelle also has over 8 years experience in the stroke care continuum in both acute care and outpatient settings at Hamilton Health Sciences. And with that, I'll turn it over to you, Kayla, Brenda, and Michelle.
Thanks, Tina. Thank you all for joining us. We're looking forward to talking about cognitive changes after stroke. We've set out a few objectives for the day. So our goals are to identify common cognitive changes and the impact on function post-stroke, understand factors that may impact cognition post-stroke, and to be aware of how to support individuals with cognitive changes after stroke. Okay, so why do we want to talk about cognitive changes after stroke? So cognitive deficits are associated with worse functional recovery and decreased functional independence in daily activities. Also, early assessment and interventions enhance recovery and minimize functional disability. Vascular cognitive impairment is the second most common cause of dementia. And so with that, to further highlight the importance of discussing cognitive change post-stroke, we have a poll regarding the prevalence of people who experience cognitive changes after stroke. So you guys just want to take a minute to answer that.
Tina. Okay, yeah, I've shared the results.
Okay, great. Okay, yeah, so it looks like most people are pretty accurate there. So the occurrence of post-stroke depression and changes to cognition, even if subtle, are reported to affect up to 30 to 60% of people in the first year after having a stroke. Okay, so how do we as OTs assess cognition? So here on the screen are some familiar examples of some of the assessments we may use. As you can see, the MoCA, which most people are familiar with, as it's recommended as part of stroke best practices. Brenda will talk in a few slides about factors to consider with cognition and why some assessments like the MoCA may not be appropriate for all patients. Other cognitive functional tasks we might use instead. So for example, if individuals have communication impairments, we might alter our assessments accordingly. We might also liaise with other team members such as SLP for strategies and strengths of the individual. We would then tend to use more function-based assessments, such as Kishton assessment, maybe the Kettle test, wayfinding around the unit, or back to their room. Just more assessments where language could be largely removed. So such as having picture options, card sorting, maybe matching a visual demonstration, There's also other assessments we might use, such as the multiple errands test or the cognitive performance test. So the types of assessments that we would consider using would also depend on your location or site and what you have available there, as well as where the patient is in the care continuum. So for example, like acute care might have different resources than inpatient rehab or outpatient rehab or in the community. Such as the equipment that's available, the time and the feasibility of doing something that might be more involved, like a kitchen assessment. And then also depending on what the patient's goals are. So again, based on their baseline function, were they doing kitchen cooking, money management tasks at baseline, or was family supporting them for that? So as OTs, we use clinical reasoning to select the most appropriate tool to screen for cognitive change. And we always use it in context with other things such as observations, discussions with family, and so on. The impact of deficits on function and safety in ADLs, IADLs is what we look at, again, as OTs. We specifically focus on the impact of cognition on function. And again, we would choose the most appropriate assessment. So we may consult with other team members to help us sort of tease that out. So we've outlined here a short list of team members we might want to consult with when assessing cognition. So there's a variety of team members, but just to name a few: neuropsychologists who complete in-depth, detailed assessments of cognitive functioning. So often a referral is made when in-depth knowledge of cognitive functioning is required. So for things such as return to work goals, return to school goals, possibly driving as well. Also, they can assess more diagnostically. So for example, this may be helpful in differentiating and diagnosing stroke-related cognitive changes versus a dementia. Prognostics, they help us to better understand what can be expected in terms of cognitive recovery after stroke. Their assessment might also help to quantify changes over time. And we often work in tandem, so it can be used in tandem with functional cognitive assessment and guiding rehab treatment in both inpatient and outpatient settings. We might also work with speech language pathologists for cognitive communication goals, nursing. So we might look at their CAM assessments. They are working with the patient throughout the course of the day. So maybe changes or fluctuations in cognition throughout the day, or challenges even with things like selecting food off their menu, or nursing often will be present when family's there. So they might also be able to chat with family and caregivers, as they're an important part of the team as well.
All right, I'm going to take over. So as Michelle said, there are some factors that you might want to consider when you're assessing cognition and generally treating cognition as well. It doesn't sort of live in a vacuum where nothing else is going to impact it. So some of the things we thought to highlight are language. And this can be, is, English their first language? Do they speak another language? Can the assessments be completed in their first language? Can they be translated? Is it appropriate? Sometimes we look to families to kind of help with translation, but that's not always the most reliable or standardized. Like Michelle mentioned, are there language impairments, aphasias, other different things that could be impacting after their stroke? And typically we would liaise with our SLP colleagues to look at strategies to support communication. And like Michelle said, looking at maybe more function-based assessments or assessments where language can kind of be taken out of the equation. Always want to look at education level. Some standardized assessments will factor education level into their scoring. And also their pre-admission reading and writing skills should be considered. We don't want to be assessing something that they weren't able to do to begin with. Pre-admission cognitive status. So can the individual themselves kind of tell you, yeah, I was having some trouble with memory even before, and this is what I did to help? Or is family saying, yeah, they were living independently, but they needed help with this or that, or noticing little things. From my experience in acute care, sometimes those conversations are conversations you have to have over time. Family is not always able to kind of give all that information the first time. You know, you'll kind of be like, oh, how were they cognitively, you know, before they came into hospital, and the family members say, yeah, they were pretty good. And then 2 days later, when you talk to them, they're like, well, I did notice this, you know, once they've kind of had time to process and think about it. Some other things to look at are medical factors. Delirium, is there something going on medically that can be impacting their cognition? Obviously delirium is a big one, but you know, are there other things that we should be taking into account and could be corrected from a medical perspective that would impact their cognition? Mood is always a big one. Obviously we've already done presentations on depression after stroke, but mood can certainly impact how one presents in terms of their cognition. Their cognition can impact their mood. So that's always something to kind of take into consideration. Fatigue, post-stroke fatigue, attempting to sleep in the hospital setting. You know, for those of us who spend any time in an acute care setting, it is not an ideal place to try to be getting some sleep. So if you're tired and just trying to process kind of what's happened to you, and then somebody's coming in to assess their cognition, that might not be the best time. Certainly vision impairment, that can be, you know, low vision, hemianopsia, inattention, anything like that can impact the type of assessment that you're going to do. And obviously hearing impairment, making sure people have their hearing aids, amplifiers, things like that to help.
So we can put that maybe physically too, sometimes.
Oh, yes. Michelle's adding that physically we might have to alter if they're, you know, can't write because their right side is affected, things like that. So we're going to go into a little bit about common changes that you might see after stroke, and I feel like I need to take this off because I keep hitting it. So there is a wide variety of cognitive changes that are possible post-stroke. We might see changes in one specific domain, or it might be kind of a more broad across several domains. We've highlighted a few: attention, processing speed, executive functioning, memory, insight. You know, one or more of these might be impacted. There might be like a play of different things going on. And when we're thinking about executive functioning, we're thinking of things like initiation, inhibition, you know, kind of changing from one task to another, insight, planning, organization, that sort of thing. So what we thought we'd do over the next few slides is go into more kind of specific examples of things you might see kind of across the continuum. So if we're looking more at, you know, attention, concentration, processing speed, you're thinking people who have maybe a limited or kind of short attention span, they're easily distracted, you know, they might need more time. So we kind of just came up with some quick examples of things you might see. So in acute care, you know, you might have a patient and they're not really able to follow your directions. They're in a 4-bed room. There's a lot going on. You know, there's things beeping, there's visitors, there's people coming in and out. Their bedside table is covered in stuff and they just can't focus on what's happening. Inpatient rehab, you're working with a patient in the treatment room and they're constantly asking questions or making comments that aren't really relevant to what you're trying to work on. Can't really keep them focused on task. And then outpatient rehab and beyond. So your client appears attentive, you know, they come in, they're making eye contact with you, but they might take longer to respond. They might need repetition. I might have difficulty, you know, if you've got the radio on or somebody else is treating in the treatment room as well, they're having difficulty kind of focusing and staying on task or kind of switching between tasks. So that's kind of what it might look like. Another common one that we see is memory. So, you know, I think we're probably all pretty familiar with working with people with memory impairment, whether it's from the stroke or from before or made worse. So these are the people who are a bit forgetful. They're not really able to, you know, carry over information as well from session to session. So in acute care, you know, it might be somebody is not really sure why they're in the hospital. They might keep asking to go home or why they're in the hospital. They might not be able to correctly recall information about their journey in the hospital. So, you know, their family member comes in and says, you know, did you have this test this morning? And they might not know, or they might kind of mix up the information. In inpatient rehab, you might find that these are the patients where you're like, "Ugh," you know, we're continually doing the same thing over and over again because they're not able to carry over between sessions. So you might review strategies for, you know, meal prep or for transfers or for ADLs, and they're not able to recall this information between sessions. So you're finding that you're needing to use, well, I won't get into that, but you're finding that you need to repeat yourselves and things like that. You might also find the individual can't kind of find their way back to the room after their treatment session. For outpatient rehab and beyond, you know, you might notice it more as difficulty recalling appointments. Maybe they're missing your therapy appointments, or they're not completing homework or tasks. You know, maybe there was things they were supposed to do between session that aren't getting done. And they might have some difficulty kind of explaining how they spent their time between sessions. And then looking at difficulty with insight, judgment, and impulsivity. So these are the people who, you know, maybe are acting or kind of responding quickly. You know, they might answer your question before you finish saying it. They might not have a good sort of judgment of their, you know, abilities. They might make decisions that, you know, we're kind of like, oh, that wasn't the safest decision that you could make. They might be at risk for falls or not really getting, you know, yeah, you got up and walked to the bathroom this time, but it didn't look very good. And next time you might not make it to the bathroom, and what happens if you have a fall, that kind of thing. So in acute care, you know, this is the individuals who are maybe attempting to get out of bed independently when they require assistance. They might be, like I said, answering questions before you finished, or answering inappropriately without considering kind of the answer or the consequences. In our inpatient rehab setting, you know, they might not be accepting of some of the supports that you're trying to put in place for them because they don't realize that they're having those concerns. Or, you know, maybe you're trying to put in some memory strategies and they're not really accepting of those because they don't see that they have any difficulties. And outpatient rehab and beyond, they may have difficulty. Typically in outpatient rehab, we want people to be coming in, you know, really clear with their own goals, and they might not be able to identify their own goals, or they might be, you know, kind of saying, yeah, doing great at home, and their family members in the background going, no, they're not. You know, so those kinds of things. Or they might have kind of unrealistic kind of goals or ideas about what they're able to achieve. So I think we have another poll.
We do have another poll. Yep.
Okay. Now I think.
Yep. So we'll just give you a few seconds to kind of read this over.
Thanks. We'll try not to hit the microphone.
Okay, here are the results.
Yeah, I can speak to it. So, yeah, you enter the room to reassess a client you saw the previous day. Your patient does not remember you and states you can't expect me to remember all of you. So a client in acute care, they are meeting a lot of people throughout the day. And our question was just around what areas of cognition may you want to consider investigating? So memory, attention, insight, all of the above. From our perspective, we're kind of saying the right answer is all of the above. Yeah, they're all correct, but the right answer is all of the above. There are many reasons why a client might answer in this way. It could be they don't actually remember you. It could be they are really genuinely meeting a lot of different people throughout the day, and when they're not sleeping maybe very well, they're being distracted by everything in the room. They particularly, like, say you came in and there was 20 things happening. If it's a ward room, they may not have gotten that information in that they met Michelle. So it really just kind of, we wanted to use that poll question to sort of highlight the overlap.
And then also saying the comment about you can't expect me to remember all of you could be them somewhat masking, so the insight could play in there as well.
Yeah. So all three.
I can do this.
Okay, great.
So I'll jump in. As part of our presentation, our third objective was really wanting to look at and provide you guys with information on how to support clients with cognitive changes post-stroke. So we have a client, we've assessed them, we sort of have an idea of what perhaps what some of their deficits are, but then how do we support them? So whether you're briefly meeting with a patient once to do a test and procedure, maybe once to do an appointment in an outpatient clinic, or you're working with them on a daily basis. One of the things that we wanted to talk about were some general strategies that can be used to assist and support individuals with cognitive changes in almost all, or if all contexts. So whether you're in acute care, inpatient, outpatient clinics, in so many different contexts, these are really foundational. And if we can be applying these sort of strategies in as many situations as possible, it actually helps optimize outcomes for clients. So number one, trying to always introduce yourself when you're working with a patient. As we talked about, they see many faces day to day in their stroke recovery journey, and you shouldn't assume that they remember you. And a lot of these strategies might seem like they're common sense to us. But if we think back on our interactions with our clients, we want you to really consider, are these things that you're doing consistently? Because they really do make, like, they seem small, but they really do make a difference. So our second example is reducing distractions. So do you have an opportunity to pull a curtain or clear off a bedside table to reduce visual clutter? When possible, utilize options for quiet workspaces. So rather than a busy gym, is there a quieter hallway? Many units have lounges or sunrooms, spaces where there's less like auditory and visual distractions for clients. If you can't reduce the distractions, maybe there's someone else in the room getting a test. Is there an opportunity to come back later? Because say your assessment and your treatment might not be as effective. And so, yeah, kind of timing it as best you can. Another strategy is breaking down the task. So as often as possible, giving one-step instructions or simplifying if you are observing some of those things that Brenda talked about in terms of reduced attention or reduced memory, breaking tasks up, or even parts of an appointment into shorter steps or pieces when able. Allowing time. I know this is, again, often in our context, we don't always have a lot of time, but it really is so effective for clients. So giving clients time to process instructions or requests, pausing after you've asked them a question, to give them time to respond, giving opportunities to ask questions, rather than just assuming that they will offer their question. And again, all of these apply in so many different situations. And one of the things we wanted to highlight was, as we go through these general strategies, is communication among team members. So whether this is nursing, physician, SLP, if you're aware or you notice through your time with a client that a strategy is effective, we really encourage you to communicate that with the team. The more that we can be consistent in implementing these strategies, it's going to be optimize carryover for clients, and better optimize their cognition early on. Okay, yeah, so some more strategies. So this is more of an external strategy, but provide written options for important information wherever possible. So write down information or provide handouts. Say you're meeting a client once, can you write down the information? Say you're seeing them in the clinic, or if you're not sure that they're going to be able to carry this over and tell their family members, providing handouts. For some clients, encouraging the individual to write down their own information or their own notes. That can often help with memory and carryover. The process of writing things down can help. Use of calendars for appointments. Consistency with appointments can also be really helpful, as we know routine. Routine helps with memory and carryover. Another strategy is avoid quizzing. So rather than asking, do you remember the date? You can try, can you tell me today's date? Make it a bit more conversational. It can often help with clients' anxiety, their mood, when they're feeling, or even actually even language impairments as well. When people feel sort of confronted with conversations, it can be hard to get information out. This is also a really good strategy and kind of ties into the second one. So involving family and caregivers as much as possible. We as team members can communicate about the benefits of using some of these general strategies with clients, but teaching family members as well the importance of applying general strategies can be really, really helpful. I know for me, I often have family members who will answer questions for clients, or I'll ask a client a question and they immediately jump in, where perhaps if we'd given the client a few more seconds, they would have been able to respond. Family members can also reiterate information or practice different strategies. Encourage, like for example, encouraging clients to review the written reminders, or reminding them to make notes. They can break down tasks into steps. They can help to reduce distractions as well. And the more consistent that we can be in applying these general strategies, the better outcomes we have for our clients. You go back.
Sorry, oh no. There we go.
Okay.
Sorry.
And this is our last slide of these general sort of overarching strategies. So visual reminders, these are very familiar to all of us. So this could be, an example is color-coded tags on mobility aids. So red for assistance, yellow for supervision, green for independent. This could also be signs posted in the room. One strategy, so an example is, remember a client to call for assistance, or a calendar, things like that. We really encourage you to get the patient to choose the wording of the sign if possible, the location, to kind of create meaning behind it, so that they can kind of, it's not just like sort of something that somebody put up and they don't recognize the significance, but involving them in that process. Where possible, altering the environment, so moving patients closer to the nursing station, or reducing distractions in a room. Where possible, if you feel like it would be beneficial for a client, reducing the number of people in the room to help kind of optimize overall cognition. Again, being consistent, so really kind of driving home the point that if there are strategies in place for a patient, really try and encourage the team to consistently use these strategies. We know that routine and consistency is beneficial for cognition overall. And our last sort of strategy is providing gentle feedback. So particularly with our clients with, say, impulsivity or reduced insight, providing feedback, but in a gentle way. So I did notice you made an error there, or this task was a little bit harder for you, using teach back methods as well. So having a client explain a concept to you, or how they're approaching a task, it kind of helps to build insight. Yeah, that's everything. We're going to move on to the next part. So as we said, those are sort of the overarching concepts that we're going to recommend that you apply in all those situations, or apply in many, many situations. And now we're going to talk a little bit more specifically about more specific cognitive treatment approaches. So these treatment approaches are discussed in the Canadian Best Practice Guidelines. Two examples of cognitive treatment approaches include remediation and compensation. So we as OTs choose to use treatment approaches within one or the other domains, or something else. These are just two examples, but likely it's going to be a combination of a lot of different treatment approaches. So determining treatment approaches depends on many factors. This could be the individual's goals, an individual's strengths and weaknesses, where are their areas of deficit, their current cognitive status. So what are we noticing in terms of learning and carryover over the period of time perhaps that we're seeing them, and the individual's communication abilities. So we're going to talk broadly about these two treatment approaches, and then also kind of get into some more specific cognitive treatment examples. So remediation. So remediation is focusing on providing intensive, specific training to directly improve the impaired cognitive domain or underlying skill. So generally these examples are going to look more like pencil and paper worksheets that target specific domains. So you might do a worksheet, have someone do a word search, and really you're trying to optimize their sustained attention for a period of time, as an example. Remediation could also be repeated functional practice of a specific skill or task. So say counting money, practicing the underlying skill of accuracy in counting money. This could also be math problems or calculations, things that are a bit more functional. Remediation might also look like having a client complete computer or tablet-based apps or tools directed at specific deficits. One of the, and I'm sure you're familiar with this, one of the concerns about remediation, as we're providing intensive specific training to look at underlying skills, there is some concern about how this generalizes to functional tasks. So you practice a specific skill on an iPad app. How does this carry over functionally in everyday life? Are we really just getting better at that iPad app, for example? And so we as OTs really try to, while also remediating under the underlying skill, be as functional and meaningful as possible, because that's going to optimize generalization to the patient's overall life. The other kind of domain is compensation. So teaching strategies to manage impairments directed at specific activity limitations to promote overall independence. So compensation could be changing the physical or social environment to accommodate for cognitive changes. This is where some of these general strategies we talked about come into play. So reducing distractions, using routines, breaking tasks into steps, giving yourself more time, changing the way a client performs an activity could also be a compensatory strategy. So use of a journal or a memory book to assist with memory. That one's a little bit trickier, because many times if a client is at the stage where they need something like a journal or a memory book, it really is important to have family and team member involvement to help to help facilitate it. A client who needs a memory book for memory may not be able to implement that independently because they have challenges in memory. So that it's a great strategy, but it really does require a team approach and family member approach. Compensatory strategies could also be things like use of timers, writing down important information. Sometimes it's using sort of metacognitive strategies, so things like active memory strategies like visualization, relating to what you already know, forming an opinion. Sometimes clients or family members, when they hear the term compensation, they're like, oh, but I want to get back to my normal function. People don't necessarily love compensation, but I always kind of go at it the approach that, like, these are strategies that all of us use in our everyday life. The fact that I write down in my agenda my appointment times or tasks throughout the day is a compensatory strategy. And so, yeah, I often use that example to kind of encourage clients that this is not, we're still assisting and we're still optimizing cognition. It's just a different way of doing it. And again, using a combination of approaches, both remediation and compensation can be valuable. That way we're kind of, we're approaching it from different angles to try and find what's going to fit best for the client. And we have another poll question. So we'll just get Tina to put up our last poll question. Okay, so we've given you a little bit of time for the poll. So which of the following treatments would be considered remediation approaches? So locating a list of grocery items in a flyer, math worksheets, we can't see the whole question, setting up a blister pack for medications, using a calendar, use of alarm and timers. And yeah, so 81% of you answered correctly, locating a list of grocery items in a flyer, math worksheets. These are all practicing kind of that underlying foundational skill. So yeah, great, excellent.
Oh, I did it again. I am.
So we're all going to kind of hopefully jump in here. We thought, because many times when I'm talking to other colleagues, they say, okay, well, I've assessed, I know this person has impairments in insight, or I know this person has impairments in memory or attention, and we're using these strategies. I'm trying to reduce distractions, etc. But then what do I do? What do I do? So we thought we'd talk about some of the things that we actually do.
Yeah.
If you have the opportunity to work with a client more than just very briefly.
Yeah, and we won't go into too much detail because not everybody here is going to be doing cognitive treatment, and that's not really the focus of the presentation, but we just gave a couple examples. So one example that we've kind of put up here is using a menu. So can do money management, can do kind of problem solving. You don't eat this, but you eat this. What can you get? You have this much money, or you want to spend this much money. What could you get from this list? There, and it's a great opportunity to also grade activities, right? Mm-hmm. So you might be able to say, okay, can you find everything on this list that you could on this menu that you can get that's under $10? Mm-hmm. And start really simple. Or I want you to pick one thing, that's between this amount, and then you can get more difficult, right? You're planning a menu for multiple people, and you're endlessly able to grade an activity like that.
Yep. Or even like something else is you have the radio on in the background to sort of simulate the busy environment of a restaurant, right? Managing that auditory distraction. The other example that we have here is medications and dosettes. So medication management. This is reading on instructions, understanding those instructions, sometimes complex instructions like take 2 twice a day. Mm-hmm. So multi-step instructions. This, it incorporates divided attention work, executive functioning, problem solving.
And also really practical, right?
Yep.
Oh, look, that went really bad. Every time we've done it, maybe you need a blister pack,
yep,
right?
Exactly.
Or maybe family needs to support you. So that can help even with insight as well.
Great. So you can see on the screen there, this is one of the tools that we have here at Outpatients, but Brenda put it on the slide as kind of an illustration again of remediation. So this is something we call the BITS. It's like a big touch screen, but this could also be, say, your iPad, right? A client's iPad, but computer-based programs and iPad tools. We use this or you could use this in multiple ways. So practicing applying different strategies like reducing distractions, navigating, accessing a computer. So you're practicing like, where do I click to get to my email, for example, or again, in different contexts. Some of the apps might be remembering a list of functional words, or practicing some of those cognitive strategies to remember what you want to remember. Dividing attention, exactly. Yeah.
And then the other example up there is just something I know lots of us OTs like to, make things up and try to find things that'll work for our clients, challenge our clients. So this is just an example of something that we've used here. You got to go do these tasks, but kind of follow these rules. And, I sort of think of it as, you're busy in your day and you got to get these 7 things done, and how are you going to get them done? So it's kind of along those lines. And then watching how people kind of do in those less structured tasks sometimes can be really telling for us and for them. So just kind of another kind of task that you might you
Yeah.
might do with people.
Planning, organization.
Exactly, wayfinding, all those kinds of things.
Yeah.
So I think those are examples. I'm sorry, I saw somewhere some of our slides are cut off. I don't know why. It looks beautiful on our screen. But we have time for questions.
And I believe Rhonda or Tina said in the chat that we are going to share these slides afterwards, so you'll have them available.
Yeah. Well, thank you. So if anybody has any questions, you can use the Q&A, you can write in the chat. You're also welcome to raise your hand if you'd like to ask it verbally. That's also fine. So while giving just a few minutes to do that, want to highlight, yes, that tomorrow there will be a follow-up email, and it will have a link to the recording, and it also will have a link to the presentation. So we do have a question from Stephanie Stone, and she's asking, any good tips for Port Insight?
I don't know. I'll go
Okay,
first, and
you
then
go
Kayla
first.
can.
Okay.
Port Insight is really challenging, and
Mhm.
sometimes it can be a very painful process to try to build insight. And I find, you know, and I tell people, you know, this might not be fun, but we really do need to build your insight, because if you don't know something's wrong, you're never going to try to fix it, right?
Mhm.
And I find good ways to do that are things that are objective, right? So, you know, things where you actually can make a mistake that they can see. Because if I'm just telling them, oh, hey, your transfer, that wasn't very good, they're not gonna, that's not gonna be meaningful to them. They're gonna be like, well, that's your opinion, right? So
Along
anything,
with that too, Brenda, like sometimes the more standardized assessments, like if you're able to do them and
Yeah.
you can objectively say like, this is the normal cutoff and this is what you scored or something.
yeah. Or, you know, you do a kitchen assessment and you're like, well, you know, the egg's on the floor and the stove's on and nothing's on the stove, you know, whatever you can do to make it kind of obvious, I feel like is one of the things you need to do to try to build insight.
Yep. And sometimes it is also just like kind of a professional self-reflective process, right? Getting comfortable with sort of saying, okay, I don't like, it's hard, right? Getting comfortable with saying this is probably not going to go well, but it's an important process that we need to go through. I know sometimes I really have a hard time with that, because I like to be nice to people, right? And sometimes people are not gonna, they might not respond well. Yeah, but I agree. I think that objective information is so valuable.
And sort of letting people fail in a safe environment.
Yes.
Right.
Okay, we have a number of questions in the chat, and I'll start here, one in the Q&A. What other apps or up-to-date IADL treatment tools do you use focusing on technology?
Well, that's a great question.
Yeah. Okay, so we can talk a little bit about what I do here in outpatients. So I try to be really goal-oriented and task-specific. So is there an opportunity for a client to say, bring their laptop in if they feel comfortable, or if bring their iPad in if they feel comfortable, trying to make it as task specific as possible. So do they want to get back to email? I've had a client where we practiced entering and exiting Zooms, because that was one of her goals. It's hard when a client's goal is, I want to get better at the computer, or right, like breaking it down, really trying to probe and to say, okay, what are the specific tasks? You want to be able to get onto the internet and read the news, right? Sometimes, depending on the client's level, that could be breaking it down step by step and written instructions. That's what I did for this client who wanted to be able to access Zoom, and we repeated it a few times. So the repetition was also valuable. She could refer back to her instructions. iPad apps are kind of, they're a bit of a hard one. I'm sure you've heard of some of the, like, is it the Lumosity? We will also use another one that we find to be a bit more functional. It's called CT therapy. There's a clinic-based kind of version and a home version, it is pay, but I find that that one will give, you know, an example is like it's following instructions or reading a passage and answering questions about the passage.
Some of the Tactus apps too.
Right, and so for speech, some of the Tactus apps, so there's like advanced writing or advanced reading, those ones are also pay, but we do find one of the benefits of technology in some of these apps is it can provide the massed practice that a client needs. So for example, I can't give them 50 worksheets, right? But there might be an opportunity on, say, an iPad or a computer based application for them to do 50 questions, say, for example. So that's one of the benefits. Yeah, so Tactus, CT therapy, and focusing on kind of breaking down what is their actual functional, like, can they give an example or probing to kind of explore what's their functional goal related to accessing technology.
Okay, thank
Hopefully
you.
that answers your question.
And there was, I was going to say, Stephanie had shared, there was otiadl.net, which may not be another resource that may be there.
Mhm.
Okay, great, thank you.
Yeah, so we've got some thanks in the chat. And now there's a question. Can we use the assessment of motor and process skills tool for this population?
You can't
Yes. So I think you're referring to the AMPS. Yes, I think the AMPS would be great. Actually, both Michelle and I are AMPS trained. One of the we'll talk about the pros and cons of this. So the pro is that I do find the AMPS to be really effective because it gives it kind of scores a client on so many different domains, physical domains, which may not be applicable, but cognitive domains as well. So how are they sequencing a task? Are they noticing when they're making errors? Say, for example, the downside of this is I don't know whoever asked this question was the AMPS, from our understanding, is no longer being offered in terms of training and support for the application where you do the analysis. I think it's called the OTAP.
Yeah.
I don't know whether this is pandemic related, but decided to not have the books, like not offer the books anymore, not offer the training, and no longer support the computer application that helps with interpretation. And so that's quite disappointing because we both, it's a really excellent assessment and can be used as a bit more in-depth objective assessment, but yeah, that's kind of the downside. If you're trained, that's great. And I think there's potential to still use it. I think with the licensing agreement, I think.
Okay, thank you. Yeah, that was a question from Carissa. And Rachel is asking, can you share the list of apps that you use for the tablet?
Share a list. We do have a list potentially. Yeah,
We could
we'll
make
hunt
one.
it down. No,
Yeah.
we do have one.
Oh,
There's one
okay.
on the SharePoint.
Oh, okay.
Great.
Yes, sure. Yes, of course. maybe send your email to Tina and we can forward it on.
Okay, yes, absolutely happy to do that.
With what's the word I'm looking for? Like a caveat that it is very hard to keep up to date, I find personally, with all the apps and websites and things like that. So that to me is always the challenge. I know whenever we have time or sometimes when we have a student, we'll be like, hey, can you try to update this? Is there anything new? That part is very challenging because most of us do not have time in our schedules to do that.
Or I will be honest, sometimes there's an app that we use pretty regularly for a specific remediation, and then one day we go on and we're like, oh, it's not supported anymore. Yeah. Or we recommend it we show it to a client on our iPad and they're like, oh, I love this, I'd love to put it on my iPad, and we can no longer download it. So there is kind of that sort of ebb and flow.
Some are not compatible with iPad versus tablet.
Yes, some are not compatible with iPad versus tablet. So
okay, thank you. Miriam has two questions. Number one, noticing that we are starting to have a lot of younger patients. Recently, I've gotten a question regarding Is it bad for me to use Instagram so much after my stroke? Patient was in their 20s. I noticed not a lot of literature on this. And then was also curious if you know any new cognitive assessments instead of the MoCA that may target a younger population.
I think those are really good questions. So
Yeah.
I'll say in terms of assessments, I'm always kind of looking out for new assessments and not really finding anything. I don't know if other people are experiencing the same thing, because a lot of our assessments are, well, I've been using them most of my career. So when I'm not going to admit how long that's been. So there's that. Like, I don't know if there's a lot of newer assessments, and I guess new is a relative term, you know, is new within the last few years or new within 10 or 15 years. I know a lot of the assessments are tending to go more function-based, which I think as OTs is something we like. As for the Instagram, I don't know a lot of literature.
Just
about
the
that.
one comment I was going to say about different cognitive assessments. One challenge that I find is when I'm doing a cognitive assessment, right, it's helping me get information, but I also need to communicate that information to, say, a physician or team members, right? So I often think of like how we're using that information. So for example, sometimes I'll do an alternative cognitive assessment and have it in my note or report. And I've had times where people are like, well, I don't know this. Like, what does this mean, right? Like one of the benefits of a MoCA is people kind of, well, maybe not the MoCA, there's other things that, you know, we all have feelings about it, but in that it is stroke best practice, right? We use it as a communication tool, right? Which is the benefit of having a kind of a best practice tried and true. When we incorporate new assessments, sometimes people don't always know the significance of those. So I think it just takes time when we introduce new ones to sort of have that kind of dissemination of knowledge. I think that your question about Instagram and social media is really fascinating. My own personal opinion is I think it would be interesting research to think about how it influences attention, definitely. Those short, like particularly Instagram or TikTok, I'm thinking like those short snippets of attention, not really helping our sustained attention, perhaps. But yeah, it would be a fascinating area for research.
Okay, so and just on that, Susan has mentioned that she uses the cognitive linguistic quick test, which is a cognitive screen that measures the same domains as the MoCA and is valid for 18 to 89 years. And she says she likes to use this when she cannot use MoCA due to age.
Yeah, here our SLPs tend to do that one.
Yeah, I've done it a couple times too.
I have done it, yeah.
Okay, and Rosalind also has said that she's used that a few times. Okay, thank you. There's still a few more questions. We have a couple more minutes. Try to squeeze them in. How can we improve inattention and neglect? And could you also explain the difference between the two?
Do you guys think there's a difference? I tend to use inattention as opposed to neglect. Okay. The terms, in my experience, have typically been used interchangeably. I prefer the term inattention because the person is not trying to neglect something. It's just their brain sort of pays less attention to the left side and is much more easily drawn over to the right side. So that's my term. I don't use neglect, although I know lots of people do. I can talk about
I think I would agree with that. Like I don't typically use neglect. I think I read in a textbook once that, you know, an individual with, say, a true neglect has no concept of that side of space. And it's like the deficit is quite persistent and doesn't show a lot of improvements with treatment, just because their whole kind of concept of that side of space. I have met a few clients like that. I find more clients present with an inattention and not really a true neglect, in that it is sort of, you know, with say scanning strategies or other interventions, we do see improvements, and that we can see that they're able to to attend more to the other side.
Yeah, and then I think we make use of, I've had a patient very recently with a very significant inattention. And we sort of make use of all the strategies. So things that are meaningful to them on the left side, and to be honest, not even the left side, we were just trying to get to midline because she was not able to cross to the left side. And then making use of visual, tactile, auditory stimuli. We looked ridiculous jumping around in our bright clothes, just trying to get her over to the left side. You know, anchors on the page. And I think, like I say, trying to mix like the auditory, the tactile, and the visual stimuli to try to get people over and to make it meaningful to them. So, you know, you're into, I don't know, heavy metal music. So I'm going to play it over here and have a matching album cover of some band I've never heard of, but it's meaningful to the patient. So, you know, trying to do things like that.
Okay. So there's still a few more. We'll keep going until 12. Are there any assessments you would recommend focusing specifically on short-term memory other than the MoCA?
I haven't used any other ones in a long time. I mean, obviously there used to be like the Rivermead. I don't even know if it exists anymore. So we don't have it here. You guys have,
We have a very old version.
yeah.
Yeah.
And you guys have the
contextual memory test. We often use the picture version for language.
Yeah.
But we do have both versions.
Yeah, Brenda was just, I hope you guys heard the Rivermead behavioral memory test. We happen to have an older version, but there is a newer version that looks at like prospective memory, so remembering to do something in the future. And it is actually, it's quite functional if you can get your hands on that one. The contextual memory test is a little simpler in that it looks at how someone is remembering pictures. So with and without recognition cues, that one's easier to sort of, you can do it in a very short amount of time. I'm trying to think, we might also, another one that we use here in outpatients a little bit more involved, something called the R-bands. So what is the R-bands?
Repeatable battery for the assessment of neuropsychological status.
Yes, repeatable battery for the assessment of neuropsychological status. So that looks at a bit more at short-term memory. But again, those are all, I think, probably more investment, perhaps assessments. Investment assessments than just like your standard one page, for example.
cost investment.
Yes.
Yeah.
Okay.